I think because Richard was editing ACM's interactions. So for those of you who are interested in design and interaction design in particular, this is a publication of ACM, and it's well worth looking at. Richard was editor for 3 years. He invited Raj and myself to submit an article, which is sort of the basis of what I want to talk about. And then Elizabeth wrote an article recently under a new set of editors. So that's sort of the genesis of what we're doing. The point of the article that Raj and I wrote was to talk about how we see healthcare starting to change and moving in the direction we think it needs to move in. But this begins with the idea that most people agree that healthcare is a wicked problem. Now, the phrase wicked problem comes from Horst Riddle, who used to teach over at Berkeley. And a wicked problem is a problem where people can't agree on a solution because they don't agree on the problem. Wicked problems can only be resolved by reframing, by finding shared views, values, and goals. From the point of view of today's healthcare system, health is largely about minimizing illness. So traditional healthcare focuses on treating acute problems. So the goal is to eliminate or minimize acute diseases and infirmities, and the means are medicine and other therapies, which are administered by HCPs with patients' consent. Patients have little say in the means. The problem is that traditional health management applies the tools of acute care to manage chronic conditions, where the goal is to avoid or slow deterioration and have it not lead to acute problems. But we use the same ideas, medicine and therapies, prescribed by physicians and administered by patients. And the patients may have other priorities and may not actually do what they're told. But health is more than eliminating or managing disease. So health is at one level, if the goal is health, if that's a means to a higher level. So it's a means to quality of life, and there are other things that happen at the same level. You have other goals and means, love of family and friends, having your work be valued, physical and financial security, and fun and joy. So health is a means to higher goals. It's a resource for everyday life. The requirements of health extend beyond traditional health care. So there's not only acute management or dealing with acute issues, chronic management, but there's also self-management and other means such as employer practices, social policies, providing clean air and water, food and shelter, education and stability. The way we usually think about healthcare is bound up in the language of our healthcare system. Individuals are patients, doctors and nurses are professionals, professionals care for patients, patients receive treatment. Not following a physician's orders means a patient is not in compliance. The language of acute care is ill-suited to managing chronic conditions or preventing disease, which is often framed as behavior change. Here's a great quote from the American Heart Association. The number one problem in treating illness today is patients' failure to take prescription medications. Patients' failure. But consider this reframing for Melanie Swan. A collaborative co-care model is starting to evolve for healthcare delivery. The patient's role may become one of active participant, information sharer, peer leader, and self-tracker, while the physician's role may become one of care consultant, co-creator, and health collaborator. We can imagine a better world, invent new language, develop new systems, and build symmetric relationships. We can move from health to well-being, from healthcare to self-management, from patient to experiment designer. Hopefully Raj will talk a little bit more about this. We can move from industrial age healthcare, and here Tom Ferguson has a notion of this sort of pyramid where various kinds of professional care are arrayed from primary, secondary, but self-care is almost off the map, to information age design of our own well-being, which Ferguson represents as sort of turning the pyramid upside down. We can move from power imbalance, where the HCPs have all the power and the patients are treated like children, to a more symmetrical relationship. From direction and control to dialogue and conversation. These new frames and new tools that are starting to be developed can support conversations. So we can move from a distinction which enables understanding, to understanding which enables agreement, to agreement which may lead to actions and transactions, and if repeated may lead to an ongoing relationship and enable trust and love. The new tools can build a ladder to health and well-being. Actions and events generate data and stories, which generate or support conversations and learning, which yield motivation and validation, which may yield better choices, which may help with our health and our well-being. So I have here a summary of this sort of era analysis. I won't go through and read all of this for you, but the slides are online if you care to look at this in detail. I want to end, though, by saying that this idea of reframing health as self-management parallels similar trends in design practice. Increasingly, we recognize users manage or design their own experiences. And I will go through this briefly. I think this applies both to healthcare and to changes we're seeing in design. So we're moving from a traditional design frame to an emerging meta designer frame. So where we had standalone products, we now have integrated systems of hardware, software, networked applications, and human services. Where products were manufactured and duplicated, now they're configured and customized. Where we had single function tools, we now have languages, platforms, APIs, construction kits, and kits of parts. Where the function was perhaps to aid consumption, the functions are increasingly about aiding production. Where the approach was to simplify, now the approach is increasingly about increasing choice. Where we used to think about making it easy, we now are starting to see people thinking about making it rich and subtle. Where we once dumbed down or de-skilled, we're now more open to creating an environment for learning. Where we thought of things as being completed, we now certainly recognize that software is open-ended. So, a final slide. Users act on artifacts and they respond to the artifacts, and we get this sort of loop of interaction. And we might think of this as traditional products, where designers create conditions in which this happened and they learn from this. But we might take that whole thing and think of designers learning from this whole set and creating conditions in which this can happen. And so individuals can become designers of their own well-being, I think is a sort of basic idea I'd like you to take away from this. The idea that we can move to create worlds where people are able to design their own experience. And hopefully that's a good lead-in for Raj. Just special thanks to Raj, to Paul Pangaro, to Susan, and to Richard Anderson. The talk is located at our website, dubberly.com/presentations. Thank you.
So I'd like to share with you some of my efforts to understand and frame the challenges of family caregiving. And as you'll see, this is still work in progress. There's much to be done. It's far from polished, but we have to get somewhere. So one of the key things is that family caregiving has been relatively overlooked in discussions about health and healthcare. And this is really unfortunate because the home is where almost all the action happens. So this diagram is by a friend of mine, Sarah Rivera, who has Parkinson's disease. And in 2011, she had treatment by a professional healthcare provider for 1 hour that year, which is the yellow dot. The other 8,765 hours that year, she was cared for by herself and her family. So as it turns out, her experience is not at all uncommon. In fact, I have numbers from the VA about their patients which looks exactly the same. So it behooves us to better understand what's going on at home, what's going on with family caregiving. So one of the major framing questions is who is involved? And too often we are stuck in the stereotype of an elderly patient, sometimes referred to as care recipient or loved one, being taken care of by some 50-year-old, almost always a woman, who is the caregiver. And it's a nice simple dyad with very clear relationships and roles. Unfortunately, it doesn't reflect reality. The reality is that we are often helping to take care of many people, family, friends, pets, and so on. And many people are taking care of us. And even the elderly and the children are not simply passive recipients of care. They're often very actively engaged in their own care and often helping others as well. So we really are actively involved in each other's lives. And so to better address and understand caregiving issues, we need to change our language. We need to change our mindset from thinking of the caregiver, some role which you may or may not have, to caregiving as a basic human activity which at any particular moment you may or may not be involved in. So I've done some research to try to understand these family caregiving ecosystems, and this is from some interviews I did about 3 years ago. In this particular case, we interviewed a woman, a single mother, caring for 2 children, one of whom has autism, while she's also the primary caregiver for her mother, who lives in a nearby retirement facility. And as you can see, there's a whole slew of family, friends, neighbors, and professionals involved in this caregiving situation. Currently, as part of a project that Hugh and I are co-leading called Atlas of Caregiving, we're investigating how such visualizations of care ecosystems could be improved and have more information presented in there. So another key question is, what exactly are we doing in turn when we're caring for each other? So I have asked many people over the years to share with me what was their day like. And this is an example from a woman who has cystic fibrosis and is caring for herself, which, you can just clearly see, even if you can't read all this stuff, that it's just a log of her day. She sort of wrote out for me what an average day might look like. And I used that to turn into this day in the life diagram, in which case the green dots are activities that just took a moment, like taking a pill. The blue bars are care activities that took a stretch of time. So if you're doing yoga for 30 minutes, that would be a blue bar. And the yellow bars are things that were sort of indeterminate. They happened when they happened. Like taking aspirin for a headache. Those don't usually occur unplanned. Now, it turns out that this diagram, this very simple diagram, I'm no designer, has had an enormous influence in the CF community. All of them know the details in great depth. It's obvious to anyone who treats CF, who has CF, that these are the things that happen. But they have never seen all of those things presented on a graph in this way before. And it really opened their eyes to how fractured these people's lives are. Every day is so broken up into pieces, and also just how many hours the whole thing takes. So diagrams like this, though they seem simple, can have enormous impact. I've also asked families to keep even more detailed logs for one day where different people in the family do it together. So in this particular case, it was a woman and her husband both involved in the care of her brother. And unfortunately, we haven't yet, and I've figured out, how do we present such a rich set of data? How do we show all the interactions, all the overlaps, all the coordination, all the impact? But this is something that we're actively working on right now, because we need to be able to see such events so that we can appreciate what's going on in the home. Also, in the world of health and healthcare discussions, we tend not to, in fact, look so closely at what's going on. We tend to focus on sort of the high level, on the medical activities and the interactions between patients and healthcare professionals. So to get a broader perspective, last year at an expert roundtable on caregiving that I've organized, I had the group go through a 10-minute exercise. Basically, we put up a grid on a very large piece of white paper where we sort of had different activities, different buckets of care activities across the top, and different frequencies of such activities down the left-hand side. And then we gave people Post-its and really asked them to just write down all sorts of different activities that they knew about in caregiving and put it in the appropriate places on the board. And when we got done in less than 10 minutes, what was interesting was to note how many of the Post-its had to deal with sort of just activities of living, about life in general, rather than sort of medical and healthcare tasks, and how much of the action was of the moment-to-moment, day-to-day variety. And yet, in contrast, most of the innovations that are being developed to target caregiving have to do with those relatively infrequent healthcare interactions. This is one of my areas of concern about the importance of patience. So I've spoken at Medicine X on stage saying that I really don't like all this focus on patience because that implies the existence, the current presence of the health professional, whereas most of the time they're never there, so let's stop talking about patience. Off my soapbox there. Another important question is how do things change over time? So you've often seen these representations of a patient's journey, the expected progression through different stages of a disease. And while these journey concepts are indeed really valuable, if you've got some new condition, it's helpful to have some idea of what's coming up. They are also sometimes make us forget that life is not so simple, not so unidirectional. So this journey model was published in that Reframing Health paper that Hugh described to us. Attempts to show some of these dynamics in real people's experiences. Other than birth and death, there's no beginning or end to this diagram. But just to move from left to right, we start over here with sort of unstable health, disengaged patients, and so forth, and we move through various steps to the point where their health is stable and they're very actively engaged in their health. But then we also note the kinds of things that can push you back. And recently, in some work I did with the type 1 diabetes community, we found that the model was incredibly useful in showing how different patients' journeys have how we could display them. So I'll give you, in just a moment, a link to sort of be able to read this stuff in detail. But for the moment, this is a story of one story that we made up from lots of interviews we had. But in our particular story, at 1, a young girl is diagnosed with type 1 diabetes. By 2, she and her mother have learned to cope with this illness by living a very regimented life. At 3, they discover that it is possible to live more freely and still manage that disease. And slowly they loosen the reins and learn how to have, if you will, a more carefree existence, and she's still doing well. That's by 4. Unfortunately, at 5, when she goes off to college, there's a dramatic downturn in both her health and well-being in general. And so by the time we get to 6, her health is again in a very sad state. And this diagram was helpful for people to see that just because a patient has moved to here doesn't mean that everybody can go off and life is happy. Things are constantly changing. And so we're now using this model to consider what health professionals could be doing at different stages in the journey, and also what they should avoid doing to help patients along. So just to close, to learn more about these issues, you can read this report, which is the outcome of that expert roundtable. It's called Catalyzing Technology to Support Family Caregiving, and you can get it at bit.ly/caretech14. And you can also follow the Atlas of Caregiving project that, as I said, Hugh and I are leading at the moment at the Atlas of Caregiving website, which is simply atlasofcaregiving.com. And in the models section of the website, you can get a lot more details of all these different models that
is some ideas that have come from working with a bunch of folks. And the word wealth we came up with as just a bit of a play on words, because there's this idea that well-being and everyday well-being, actually personally, but also from a whole national point of view, we could actually improve the wealth of the country, the wealth of the world, and our own personal wealth, if we think about well-being and health differently. And so I'm here talking, but where this already started was a workshop that was funded last year in Europe. It's one of the Darshall workshops, that are computer science workshops, so foundational research in computer science. So there's a bunch of folks that came together and started to think about this relationship between foundational and fundamental research and applied research in this space of well-being. And so one of the things that I've always struggled with in my career, in good ways, a good sense of struggle, is to think about how you take foundational primary research and turn it into application. But how I've obviously worked in industry a long time, as someone who's always interested in applications, ends up drawing on foundational primary research, which might be very specific to its topic, say psychology, and then turning that into design insights. And so what we were trying to do here was bring together a lot of very, very, very smart and dedicated academics who are working in very specific and specialist areas, like psychology and sociology and computer science, and distributed systems, to think about how their work, which maybe is being published in very specific journals, might actually be applied through conversation to some of the issues around health and well-being and the design of technologies. Because as many of you know in this room, I'm sure, when you're actually publishing your papers and you're in the academic context, it's a very specific domain to which you are speaking. And I don't know if anyone else in this room has had the experience I have, where I used to do very theoretical psychology, and when I actually tried to put a paragraph in that motivated that work and said, and why this matters so much is we're going to redesign the world, and the reviewer said, yeah, we don't care about that bit. The applied piece was not what they wanted to see. So this Darshall workshop was really about bringing together this loose confederation of researchers to think about how their research could be applied to some of the problems that maybe here in Silicon Valley we are more used to formulating as design and technology problems. And there is a report, and I'll put this back up again later, but there is a report you can read. And I think that what we were really, really interested in was not the fact that many of these fitness devices are just like, they're the most gorgeous, beloved of the athletes and the gadget and data geeks, of which we have many here, right, in our area. We love them. That's not who we're thinking about. We've heard a lot today about managed care and people who need managed care who actually have diagnosed health problems. And managed care is being taken care of, but non-adherence to particular regimens is a problem, which is a foundational and fundamental psychology issue. And we care about that. But where we were really sitting, or I should say, this is where Elizabeth is really interested, is the well-intentioned recalcitrant, like me. Some of you might be that too. Where you start trying to get fit or healthy or self-care. Rajiv mentioned self-care, you start down that path and then you sort of give up, fall off, you abandon. So we're really we got really interested in this space. And one of the things we came up with is this idea of the new normals. Because if you think about a lot of the data collection from these fitness apps, there's this sort of sense of how many steps should I take in a day? What works for the average person? It's sort of imposed upon me, sometimes for good and sometimes just not for good, actually. So what is a normal body anyway? So these are really important questions. And how can we rethink some of these benchmarks to think about this normal for me without it being a chore? So this is one of the questions that we were raising. And we really wanted to think about this idea of well-being. Has anybody done one of those competitions, when you're counting your steps, and like by the end of the fourth week, you want to flush the thing down the loo? I think there's this sort of very interesting thing where people talked a lot about this collaboration versus compliance, and then you get into this odd relationship with the tools that are supposedly helping you, because it's not actually about well-being in the end. You don't actually feel good. And so we had this concept of burnout, designing for breaks and backing off. And this was from, these are sort of quotes from talking to people and interviewing people, but I love this one. It has to make me feel beautiful inside and out, as opposed to accounted for and like I got an A or an A+ on my exam, which is just like human motivation, the psychology of motivation. Nobody likes that constantly, right? So some fundamental research needs to be done in motivation, and this distinction between this rational, I'm going to achieve my goals, and that fundamental non-rational, sort of human sense of well-being and enjoyment, and being allowed to not just constrain oneself. So some fundamental research in that space needs to be done. We also really need to think about data and measures and metrics, and so one of the conversations we had a lot about was, what are these data that are being collected? Just because it can be counted does not mean that it's important. And some of the things that are not being counted or captured in some sense and represented may be the important things, and it may be that they are the important things for me. And just because something is measured doesn't mean that it's the right metric for me. So how do we start to come up with metrics? And the reason we wanted to think about these concepts of, so I said there's a whole kind of loose confederation of academics coming together to think about this. Some of the folks we had in the team and who are still corresponding are policymakers. They're interested in policy. Because the macro-structural issues around how you, what you can do at work, you may genuinely not have time to do something. So if we can change some of the work environment things, you end up with a macro-structural thing that maybe, the insurance companies have some different relationship to you, and then down at the Fitbit level or whatever, you've got the micro-structural things. And these really do need to play off with each other. So we're trying to get those conversations at the societal to the individual level being meaningful around the sense of well-being. So again, there is a longer report. Please read it. But partly why I'm here is to kind of invite people to help us think about this. And one of the things that I'm going to be doing very soon, just as a sort of informal thing, is I want to start doing an ethnographic field research with fitness instructors and people who actually are the kinds of persuasive motivational coordinators of information who tailor concierge-like for you. Because I think that if we can understand how those very profoundly emotional relationships and committed relationships and negotiations around abandonment or not really work, then maybe some of the tools that we're bringing together in constellations, as for some of the earlier points, could be far better designed. So if you know any good fitness instructors who'd like to be interviewed by an ethnographer, please let me know. And thank you for your attention.
I was going to start by just saying, wow, where do we begin? I mean, if we talk about a wicked problem, and whether a wicked problem is one that's just huge or one that's wicked because we don't even know what the right questions are, regardless, even if we know what the right questions, we're talking about a huge beast here. I mean, we can change conversations, we can start having these different conversations, but how do we do tangible stuff? What's some real tangible stuff we can be doing tomorrow? What can we go all out and do tomorrow?
There is always that pull, especially in the Valley. We're so used to, well, just get on with it, right? Yeah, make the widget and so forth. And as a business, of course, you got to do that. To have something out there to sell and so forth. But those will not necessarily lead to the fundamental changes that we want. I see so many healthcare startups and we're constantly talking about this new widget is going to solve the health problem. And, those incremental changes will not do it. So we have to sort of acknowledge that we have to have both sets of conversations, the things that are going to help us make the incremental changes, the 2% improvements and so forth. But while we're also working on sort of understanding the fundamental problems that might require really wholesale changes to have an impact, to have the big movement in health improvement that we want. So I don't think you can ignore it either. You have to do both.
I'm curious as to what your thoughts are on why this has taken so long to have these conversations. Is this such a deep institution that people kind of held on to it for their own personal gain for so long? Why has it taken so long to get to this? Because it seems like this has been kind of an issue. My mother is in healthcare and has been in healthcare for 47 years, so I've seen her struggles with it for years, and she's a nurse by training, and so she's definitely always been about patient care. But she's been dealing with some of these issues all my life, and I'm wondering, what do you think is the reason? Because I think understanding where this comes from might help understand where we go or how we make this change.
Do you mean the change in the conversations and the fact that?
Yeah, the ownership of the doctors to change the patient relationship and the education of the patients themselves on taking responsibility. I mean, like I said, it seems like this is such a deep institution that has been set up, for some reason, and stayed this way for so long. So I'm curious what your thoughts would be.
I think what's one of the first uses, if you like, of the internet, obviously was community-based communication. And one of the first things to read about were what were then called empathic communities. So right at the beginning, when we were all getting online, there was this concept of the empathic community, which is people finding like-minded people or people with similar experiences. And I think that had this sort of access to information sharing, and some kind of notion of the democratization of information, and the right to ask,
Right.
and the right to compare. And so I think that we're at this point, really, because information is so much more readily available, and people are excited to share, but the brokering of what is quality and what is not. So it's become a kind of more like a meta conversation around how do we manage the information around our health, as well as take into practice that information into our daily practice and question the institutions about that. And so I think that, in the last 15, 20 years, where we've really seen everyone come online and start to share, I think that's fundamentally shifted the experience of health and healthcare and self-care and caring, and also our relationship to the experts.
I think I would add to that in a sense, we, for a long time, were willing to buy into a myth because it was working so well. And so if I put it in the sense of one of those fables or something, once upon a time, we all took care of ourselves because there really wasn't any choice of us. Most of us didn't, except for the kings, they didn't have their personal physicians, so we really were stuck taking care of ourselves. And it's only been since the birth of the clinic and in the advanced economies that we have slowly gotten to the point where healthcare professionals were taking care of us. And for a long time, the advances in both public health and medicine were just amazing. Antibiotics, polio, and so forth. And so we very willingly went along with this idea that the professionals were taking care of us, and they were doing a damn good job. And so here we are today, and we still, on the whole, believe that myth. Even though the reality is nothing has ever changed, we are still, like Sarah's diagram, still taking care of ourselves. And we're starting to see that because over the last 20 years, we found that medicine hasn't kept progressing at the same stage. There's a wonderful doctor at Stanford who's also a brilliant author named Abraham Verghese, and he wrote a book called My Own Country, which is sort of autobiographical. He graduated with an infectious disease specialist and so forth, and he got into practice just as the AIDS epidemic was hitting. And early in the book, he talks about how they approached the AIDS epidemic with complete confidence. We will have this figured out in the next 2 years, don't worry. And by the end of the book, it's the late 80s and so forth, they're so shocked by how hard it's been. And I think we found that, in the sense, all these epidemics we speak of, the obesity epidemic, etc., clearly means that simply following medical advice is not solving the problem. A lot of it for a long time has been blame the patients, that we're not, if we would just do, and we're starting to appreciate that, no, that's not quite valid either, that we don't know what's going on, that each person's health can be so different, that we have to be much more focused on the individual. I think that has helped shift the conversation.
On June 1st, 2 weeks ago, the Robert Wood Johnson Foundation has issued a $2.2 million grant per year annually, and it's entitled something like Investigator Initiative Creation of Culture of Health. So there's a recognition that what has been working is not working. So I don't really have a question except another statement that I'm part of a collaboration with Stanford, Cal, Berkeley, and even a university in Moscow to take on the issue of community health metrics, which is so daunting, it's ridiculous. But there are people who are crazy enough to try it.
And to simply acknowledge Robert Johnson Foundation, they're the ones supporting our Alice of Caregiving.
Yeah. Yes.
It's all part of their efforts to get more creative.
Yes.
Which is great.
So again, I commend you guys to check out this because it's red hot. It's an open, rolling bidding process, and the doors are open right now. And all they want is a 2-page letter of intent.
Would you agree part of the resistance of change has been the business model in healthcare, that we're changing from the fee-for-service to more of a participatory type of healthcare and a penalty-based healthcare too, like readmission rates and things like that? With that in mind, where's the drag that's happening with the patients picking up on that and becoming more participatory?
So that's the question, what's the drag?
Yeah, why aren't we seeing, the consumer really picking up on this idea of being a part of their care model? It's really that healthcare's been very, patriarchal essentially for a long time. I'm the patriarch and you will do what I say type of thing. Now we're trying to get it into a participatory mode where you are really partially responsible for your care. So, but we're seeing it, that the patients aren't really picking up on that. Their attitude is that you're supposed to take care of me, not me take care of me. So there's just, it's not happening.
Well, I think they've been programmed for 40 years to think like that, and it's hard to break that program.
Yeah, I agree.
And I think it's a huge variation. I mean, there's a massive variation in the level to which people are taking responsibility.
Yeah.
But I think there's access to information and some of the macrostructural stuff I was talking about was for some people it just simply is a resources issue. They don't have the money or the time.
Right.
They don't have yet the literacy of where to even begin. And depending on the particular kinds of issues you're confronting and facing, it can be very daunting. I mean, not knowing what it is that you're going to be told, and the insurance models and what's it going to cost me. This country has not historically had socialized medicine, and people are terrified of the hearing about the bill. Obviously, I'm originally from England, so it's a very different model when I moved here, and it's been really interesting for me to see some of the changes. But I think, with the best will in the world, for some people, it's just it's a big barrier to engagement.
Right.
The infrastructure for conversation is not really there today. We're just starting to see some places where you can actually email physicians and get email back. But one of the problems is how do physicians bill for emails? So even being able to see your medical records can be very difficult. And talk about participation, if you want to actually find out what a procedure is going to cost, try asking a hospital for that information. So there's a lot of infrastructure work that needs to be done to make this possible.
I would add a very different perspective, though, in the sense that I'm not sure I agree with the premise of your question. So the way we speak of it in healthcare is how do we get patients more engaged in their health? How do we get them to participate more in their health? My contention is we're already doing all the work. So what exactly do we mean by getting patients more engaged in their health? So in a very real sense, I mean, the chart with the blue dots, we are the ones doing it. So demanding that we be more engaged is nonsensical. Okay, instead of 8,765 hours, we should spend 8,766, but really that's meaningless. So I think there's a lack of appreciation of what we already do And so the question is more appropriate, I believe, from the patient's, demanding a patient's perspective. How can we?
I was just going to say, it's not necessarily a lack of appreciation of what we do. We may not know what we do.
No, that's
Right,
exactly.
it's invisible
So
work.
part of it is the sense of what could we do to make us people, patients, families, more effective, more efficient, all of that, which is a very legitimate question because we're spending a lot of hours, not necessarily very effectively. But the other part is just this thing that Hugh mentioned. In the healthcare system, even with the experts of a particular disease, so I mentioned cystic fibrosis and type 1 diabetes. In the last 6 months, I've spent a ton of time with both doctors, nurses, dietitians in both of those illnesses, as well as patients and families and so forth. And so these are the experts in these fields, and yet, in a very real sense, they do not know what their patients do. Because oftentimes they don't have the same illness, or even if they do, they're just such a different kind of social economic system that they do not appreciate the reality of their families. And so they simply don't know what the patients are doing, for both good and bad. So I spoke to lots of patients who pretty much use the healthcare system as what they have to go through to get their prescriptions filled, but otherwise they pay no attention, and having appreciated what they do, they actually know their health better than their doctors do, because they spend 24 hours a day for themselves, and they take notes. So it's much more complicated, and I think this language we have in the healthcare system of asking what do we do to engage patients is actually getting in the way of addressing the core issues.
Yeah, that.
I really love this idea of equipping we as consumers to become experiment designers in our health. What's interesting to me is active experimenter. When I see presentations like this and look at you experimenters, you researchers, I find experimentation to be daunting even for me, even though I'm active education. So I'm curious, what do you see as the key skills for framing to get people excited about the idea of experimentation and sort of develop that talent or skill in people?
So this is a soapbox for me. Science education in the United States needs to be reformed. When 9 out of 10 Republican candidates for president can stand up and say that they don't believe in science, we are really, really in trouble. And the scientific method needs to be taught in grade school. This idea of doing little experiments needs to be something everybody needs to see through starting in grade school.
I think there's also something really, so one of the studies I did, which is an interview study, you start to say to people things like, well, do you ever worry about how much sleep? All right, let me ask you guys, do you ever worry about how much sleep you have?
I think less than.
Do you ever take yourself to bed early because you're like, I think I need to catch up a little? No. So when you start to talk to people about that kind of thing, and you say, well, actually, that's self-care. You sort of come back to your question. You do know that self-care. You're already kind of doing it. And do you ever sort of sit down and write down, how many nights of sleep that you haven't had in the last month? And people go, well, yeah, surprising number of people. Yeah, I've got a mental calculation or whatever. And so actually, one of the ways to onboard people is to make it not daunting, and to say, actually, what you just did was called sampling. Because you actually looked at days of the week and weekends to see if there was a difference. You're already an experimenter. You're already sampling. And I think quite a lot of the tools that are coming out are really interesting. I think a lot of them are boring right now, but I think once people start to get engaged in playful ways of collecting that kind of information and sharing it with friends or just being interested, I'm not saying you're going to end up being an aficionado of the quantified self, but people find that kind of stuff fun. And, I was originally trained as a psychologist. People like to think about themselves. You just have to frame it in a way that makes it fun for them, not like they're being audited according to some normal. Because the minute it starts to come in like, I don't sleep as much as everybody else, you're either feeling like so proud of yourself because you're hardcore, or you're worrying about yourself. As soon as it starts to get comparative as opposed to a bit of interest, self-interest, I think that's where it starts to get people get into an odd relationship with the information. But I like the idea of doing informal experimentation and getting people playfully engaged.
Let's just add that it's a good starting point is to sort of tell people that it's okay to start with small experiments. We don't have to have PhDs in science or, so in terms of sleep, because I'm with the quantified self, so I'm theoretically one of those geeks. We have a great conference coming up, Thursday, Friday, Saturday, be there. But I encourage people to start really small. It's like you don't have to go buy a gadget, for example, for sleep. Just start keeping a log of every morning how many hours you got to sleep and how did it feel. And it's amazing what you might discover just in a couple of weeks of doing that. And this low level of science still counts well if you do it well. And sometimes people are scared off by the word science, thinking that it has to be big and complex. Helping people to start small, I think, would be great.
Also, I think, I'm just going to give an example. Does anybody know the game Zombies Run? You have to do it. So it's basically a game, you're running, it's just basically a running app, but it's narrativized, it's storylined. And so, I can look at the map of myself and where I have run, right? And I can look at how fast I went and what music I listened to. But my particular statistic is how many zombies I dodged. Right, and so on day one, it might be, all right, well today I'm feeling like, quantifying myself and I've run this far. But on day two, I'm bored with thinking about myself as a running person. I actually just care about how many zombies I got. And I'm sort of being a little silly, but really it's actually about making this playful and having multiple kinds of ways of indexing into the information and storylines to tell people about. Because, if I came and tell you how many zombies I killed, it might be more interesting than, did you know that I did 10,000 steps today? We also have to kind of scaffold being socially engaged with others and being interesting to ourselves and others, right? There's a question back there first. You.
You've all touched on this already implicitly, but I'd love for you to articulate point out specifically what the role of designers are. What the role of designers is in reinventing healthcare.
Oh, a big designer.
I'm curious what you mean by the role of designers. You're getting at something in particular? What's the?
Well, all the things that we're talking about are sort of experimenting, reinventing the story.
Yeah.
You're pointing at a level of framed in the conversation that we're having today about design as a catalyst for reinventing healthcare.
Well, I think for designers to not merely look at the form of things, the shape, the color, but to come up and look at systems and systems of systems, to begin with the people that are involved, to try to understand deeply all of the people that are constituents of a particular situation, to understand what the context is, what their goals are, and to use that as a starting point and use that as a benchmark. But also, I think the designer's role can be one of facilitator, to see that they can translate between different communities, different disciplines, and help people find a common point of view. I don't know, those would be some places to start.
Can I just chime in?
Yeah, please.
Yeah, I think another thing is just the methods that we use as designers, the skills that we have in, as you said, in facilitating that conversation, but just the techniques that we use are so ripe for designing these kinds of services and these kinds of products and these kinds of interactions. It's not just about designing the interface for the Apple Watch that's going to track your steps and allow you to kill zombies.
So the Atlas of Caregiving project is maybe interesting in this regard. The idea of Atlas isn't merely a metaphor. What we're trying to do is make pictures of things. And that may sound really obvious, but often, as a designer who's worked for a number of years, I find myself in meetings where it's very much Groundhog Day. And I'm sure you've all been in that meeting. Didn't we do that last week? And I often tell students, you know, other folks in the room are really not as comfortable as you might be going to the board and drawing something. But when you're in a Groundhog Day meeting, go to the board and say, I heard you say this, and draw a picture of whatever sets of relationships these people are talking about. And say, is this what we were talking about? Is this the system we're talking about? Are these the relationships? And that process of, well, just like Raj showed with the cystic fibrosis people, where, you know, it's not as if these are eminent practitioners, eminent scientists. They know theoretically what the burden is that they've put on patients. But no one sort of translated that into, here's a view of the entire day of a patient. And so this idea of making models, making images of what's happened can I think be very helpful.
I think, you know, design for me is it's a persuasive as well as a productive
Absolutely.
practice. I think Hugh's talk was a beautiful illustration of that. And what does design and thinking through a designerly lens brings is the exploration. It brings multiple perspectives, and it brings the ability to hold multiple competing perspectives at the same moment without necessarily choosing to engineer one of them until you've explored them. So design as a practice and as a way of thinking about the world is about coming up with an ontology that might be unusual, new, and fit a new set of systems or create a new set of systems before it becomes the production process of the interaction or the interface. And so it seems to me that actually it's crucially important that people who are trained in design are part of this process, because the reality is these systems and tools and technologies and policies and business practices are in fact being designed already, but potentially without questioning of those multiple facets of who the stakeholders are, and should they be the right stakeholders, or in fact are the stakeholders being positioned in roles that if you redesign the system, their role would shift, a bit like our conversation about information now being available, so the roles start to shift. And design is essentially about imagining entailments and then making a set of informed decision about which of those entailments actually achieves the ultimate goal. And holding in tension the alternatives without necessarily engineering the solution before you've understood the design space. So I think design and the way of doing design is essential here.
I would agree with that, and just to add one thing. Design is also about helping us understand what our goals should be.
Yes.
And in this sense, it's not merely rhetorical, but it's political.
Absolutely.
So it's about our values and understanding our values.
Absolutely. Yeah.
So actually, I want to follow up with what you brought up, and I think it's right on the mark. I think there's a huge opportunity that's happening that for thousands of years we've been taking care of ourselves. And what happens is the advent of commercializations of symptoms into the problems, that all of a sudden the symptoms become the problem, and then the whole industry kind of grows around it. Then people as individuals, diabetes is a good example, which is not really a disease, but the symptoms of the problems between liver and pancreas. But the whole industry is kind of grown around diabetes as a disease. So, in fact, I think there's a huge new opportunity that's happening in the quantified self area, that people are now trying to educate themselves at what it was thousands of years ago, that what our grandmother or mothers and aunts knew, and kind of following up this kind of grassroots thinking that, well, maybe the problem is actually someplace else and it's not the symptoms. And I think there's a huge new opportunity that is growing, that people are wanting to learn that how many years I should take the metformin, and I finally find out it's not working. And so going to my physicians and following up the care they give me, that you have to take my metformin day in, day out, and it's not working, how I'm going to tell this guy there's actually maybe the problem is someplace else. And I think there's a huge new opportunities growing on self-education, on these grassroots ideas, that maybe the pharma is not the solution, and maybe understanding the new way of understanding. So I personally think there is a huge market opportunity here on the quantified sales in different levels, not only just keep track of your number, but keep track of the other problems that could brew from that, from the engineering, human engineering.
I think that there's a huge opportunity on both sides. I think there's tremendous opportunities for better tools, et cetera, for us to take better care of ourselves, to make what we do more effective and more efficient. At the same time, I don't want to at all dismiss the expertise of the scientists and the doctors and so forth, because there are many things that are totally outside of our control that must be dealt with at sort of a different level. Just as an example of something that people are just starting to grapple is the whole issue of the microbiome and how that is impacting us, and in fact what we are doing right or wrong in terms of managing that. There's all sorts of concerns that perhaps the vast usage of low-level antibiotics is an underlying cause of so many of these things like diabetes, obesity and asthma and so forth. And if that's true, which I have no idea, if that's true, that's outside our individual control. So there's enormous opportunity for both the experts and us.
Let's take a couple of minutes.
Sure. I've been to a few seminars. Great discussion. And one thing that I always find interesting is there's almost never a discussion of the FDA, the regulatory agencies. It feels like the whole industry, both on the funding side and people doing things, is trying to actually move away. Call things consumer devices versus medical devices because they have to deal with it. Where do you guys see regulatory process, clinical trials in this new paradigm of people doing their own pseudo studies or individualized studies? Does the FDA go away then? Or is there a way to work better with them?
I have a couple of thoughts about that. We see in our practice that FDA has actually made a shift recently that's affected some of the large pharmaceutical companies right across the country. And 2 or 3 different ones have come to us with the same question. Namely, the FDA used to be evaluating things on safety and efficacy. And that's very important, it remains important, and we want them to continue to do that. But the change is that they are now also starting to ask about safety and efficacy in the context of use, not just safety and efficacy in the context of a lab. And that's getting designers involved in these large pharmaceutical companies in a way that starts to get at some of the stuff that we're talking about here. So that's one thing that's going on.
I think also the data collection of quantified self, I think, is a beautiful example, and a lot of people are doing interesting things. We're clearly at the beginning of all of this. I think for a lot of, certainly the research and medically oriented researchers that I've been talking to, the idea that they could collaborate with everyday individuals who would be part of data sharing and they would learn, people are very excited about that, because actually what you're ending up essentially doing is, you getting scientists to help you create field trials of everyday practice and participating in that and being part of that. So I think there's a huge opportunity for it actually to be quite collaborative, and therefore to actually get field data so that in context and everyday practice of use. I think observations are going to emerge and new questions are going to be designed, because we're actually just going to have access to richer data.
Why don't we
Sorry, how do you reconcile the use of technology with burnout and apps that are being used to help avoid burnout in Silicon Valley specifically? How do you reconcile the two, using wellness apps but then also saying disconnect from your phones and put away your phones and stuff? It seems like it's a little.
Yeah, I think sort of so we often evaluate these gadgets and apps by their daily usage. And I think that's sort of important from a business perspective. If you're counting on monetizing your app by it being opened every day so you can put an app up there. But in terms of whether it's useful to the person for their health, we should be evaluating on that. Is it making a difference to their health? So the point that Elizabeth raised, measure things that actually matter. So a friend of mine launched one of the most successful sort of diet tracking apps, MyFitnessPal. And I remember from the beginning, in a sense, they paid no attention to usage. They paid attention to satisfaction. And one of the things that Mike told me long ago was they found that people would start using the app, and maybe after a couple of weeks of using it, they'd stop using it. But he said, but during the 2 weeks of logging, they become so much more aware of what they were eating and sort of developed a better sense of what they were eating and so forth, so that then they were able to make better decisions kind of on the fly. And so whether they were using the app or not on every day, it sort of didn't matter. And I think that needs to get to the heart of the thing. So as an example, if you get a Fitbit, you wear it for 2 weeks, and you find out, on an average day you walk 6,000 steps. Why do you need to wear it the next day if today was like yesterday? You really don't. And so I think it's okay.
So they become calibrating devices.
They become calibrating.
And you can use them now and again. But I also think, we're moving into this very interesting world where instrumentation in the environment, should we choose to. We get sensors and, I like to make things Raspberry Pi stuff. You can imagine if I just get up and get on my scales every day, it's part of my everyday environment and practice. And so it doesn't feel like I can agree with you, this constant like this gets a bit overwhelming. And so I think that, as we start to put some of these sensors and recording devices into our everyday environment, to our own choosing, what we're comfortable with, then it just becomes part of the general system, rather than being very attention-seeking and sort of like a vampire for attention.
Because I'm a healthcare provider, and I know that a lot of my patients in the hospital, especially the elderly patients who aren't that used to being on their phones, they get a little frustrated because you're supposed to be monitoring certain things, and we're trying to roll out these apps, but then you notice that they just become increasingly frustrated and you're not really doing anything for their self-care. And so maybe that's a generational thing, and with younger people using those apps, it won't be as big of a deal, but it's definitely a big problem in like the baby boomers and after that.
Sorry.
This loony idea, which will never get anywhere, but we have environmental impact statements for big projects and stuff. I think anytime healthcare wants to roll out anything to patients and families, there needs to be some kind of stress impact statement, in the sense of how much of a burden does it impose on the patient and the family, and is it worth the is it worth the trouble? At the moment, with the lack of such a thing, we keep rolling them out, and we wonder why people don't adhere. And oftentimes, the benefit to them is sort of non-existent, at least in the moment. Theoretically. But,
I think it comes to service design again, because one has to think of this holistic, so it's like, how many of those other apps are you using?
Well, and I think that's the problem, because you hear one app and you hear another app, and then your neighbor in the bed next to you is using a different one, and so by the end of the day, you're using 3 and you don't know what you're using it for, so.
And I love one of our professional colleagues has instituted a program for recycling all of the wearables that are, because they do sit in people's drawers.
How she told me, I learned I could draw.
Yeah, there you go. Here you go. We'll take one last question. And I think back there.
I don't have a question, I need 1 minute for 3 comments. One question that were stated well. One was, why has it taken so long to address the problem on the surface? And the phone mentioned that about the nurse. I'm a nurse, and I know that for a long time, because of the problem with wicked individuals, maybe not just maintenance, getting involved into this discussion. It has taken a long time for clinicians to leave clinical care and join these kind of groups in the rest of the world. And a lot of times, this problem is addressed by individuals, not because they were meaning, and just because they weren't watching the problem. That's wrong. Patients being explaining designers, we need to also bring in accountability for that. In the wealth, very nice keyword, in the wealth and wellness and well-being realm, they can experiment about fitness and sleep and all that, but when it comes to having a patient suffering from diabetes or a chronic condition, discharging the responsibility from the clinician into the patient is a huge issue, and that I think is also a barrier to empowering. So there's empowerment to patients to co-manage their health, but you cannot discharge the accountability of initially to the patient.
You know, I would push back on that. I wouldn't agree. I don't think that most clinicians spend enough time with their patients to have any idea what's really going on in their lives. So unless you're willing to take on the responsibility of knowing that person's life really deeply, you cannot ever really be in charge. And so without accepting that full responsibility, which no one's going to give you anyway, but without having that, all you have is the scientific knowledge which is gained on multitudes, but you do not know that person's life. Now, which is not true in the case of acute illnesses. So if the person shows up because, you know, their blood glucose level went under 50 or something, I'm glad people are there to take care of them. But otherwise, in general, the clinical side cannot be responsible.